Ladies and gentlemen, let us begin our session. And the first presentation is endoscopic ultrasound drainage in pancreatic pseudocysts. Ivan Tereshkevich.
Good afternoon, dear colleagues. Let me present my experience of treating pseudocysts of pancreas under the control endosonography. The incidence of acute pancreatitis in Ukraine is 60-70 cases, in European countries 4,600, in the United States 1,120 cases per 100,000 population. The common complication of acute pancreatitis is acute peripancreatic fluid collection, which usually occur in the early phase. According to the contrast enhanced CT of the fluid collection, there is no wall, homogeneous, delimited by the fascial structures of the retroperitoneal tissue, can be both single and multiple. Most fluid collections are sterile, resolved instantaneously without surgery. If these clusters persist for more than 4 weeks, there is a high probability of pancreatic pseudocysts. According to the literature, destructive forms of pancreatitis in occur 47-53% of cases are complicated by the formation of pseudocysts. Now the gold standard for the treatment of pancreatic pseudocysts in endoscopic treatment under the control of endosonography. The question of choosing surgical treatment in this situation is not fully resolved. We treated 180 patients over 10 years with complication of acute and chronic pancreatitis. The majority of patients were men, almost 65%. All patients underwent preoperative examinations, laboratory tests, ultrasound, MRI, CT of the abdominal cavity, EUS. The main cause of pancreatitis was gallstone disease. Minimally invasive treatment of fluid collection was performed with complication. Compression of the distal common bile duct with obstructive jaundice, compression of the stomach and the duodenum with gastrostasis, suppuration of fluid collection. The following interventions were performed under the control of endosonography: puncture, cystogastrostomy with stenting, and cystoduodenostomy with stenting. This slide presents the main treatment methods have been used. Needles with a diameter of 19 and 22 gauges have been used. The slide shows fluid collection that has been punctured and is inspirated. The positive result of treatment was the normalization of evacuation from the stomach and the restoration of physiological enteral nutrition, normalization of bilirubin levels, reduction, absence of pain, normalization of temperature and inflammation in the general clinical blood tests. The slide presents tools for cystogastrostomy, cystotom, plastic stent, type double pigtail. The slide shows cystoduodenostomy with stenting. In the case of pancreatic pseudocysts with sequesters, we performed stenting with a metal stent. Before stenting, a puncture and the fluid collection was performed, followed by biochemical, cytological, and bacteriological examination. The slide presents the main stages of cystogastrostomy with stenting, with a metal stent and removal of sequesters. Post-operative period without complication. After complete remediation of pseudocysts, the metal stent was replaced with two plastic ones. Were removed endoscopically. Conclusions. Minimally invasive treatment of complicated acute pancreatitis under the control of endosonography can reduce the duration of inpatient treatment, reduce the incidence of postoperative complications and mortality, improve quality of life after surgery, and accelerate their rehabilitation. EOS can be used as a priority treatment for complication of acute pancreatitis with minimal risk of complications. Thank you for attention.
Thank you for interesting presentation, and we have this presentation, and we have some questions for you. In which cases do you insert metal stents, and in which cases do you insert plastic stents during treatment of acute fluid collection of pancreas?
Metal stents we insert in cases of infected fluid collections. With debris in other cases, we use plastic stents.
Thank you. And one more question. Which is the recurrence rate during your endoscopic treatment?
Recurrence rate is about 5.4%.
Thank you. Some more questions?
Thank you. Thank you very much.
Thank you.
We have the second report, fine needle aspiration and fine needle biopsy of the pancreas. Please, Lydia Tarasenko, you have 20 minutes, please.
Thank you.
Good day, ladies and gentlemen. My name is Lydia Tarasenko, and today I will give a talk on FNA and FNB of solid pancreatic lesions. At the rise of EUS, there were arguments as to whether we need biopsy of pancreatic lesions or not at all. This is historical graph showing increasing share of patients with pancreatic solid lesions who underwent biopsy. Starting from 2001 to 2009, this percentage was gradually increasing up to 50%. Current, for example, Korean guidelines contain clear indications whether we need to biopsy a pancreatic lesion or not. Usually, guidelines are not so clear. The majority of them state that you need to biopsy pancreatic lesion if clinically indicated. But the fact that majority of cases suspicious with pancreatic cancer nowadays demand verification, but it really depends on local practice and guidelines. And for biopsy, we have two options, which is aspiration, which gives us cell blocks, or just smears without tissue architecture, or we have another option, which is biopsy with obtaining core tissue. Some differential diagnosis might still be very difficult with smears, such as well-differentiated adenocarcinoma versus chronic pancreatitis. Some differential diagnosis, including, for example, autoimmune pancreatitis, might be extremely difficult, if not impossible, on cytological smears. So all morphologists prefer, well, all morphologists I know prefer core samples. But biopsy of the pancreas is technically challenging procedure. For that, we have different needle design, FNA, FNB, several generations of FNB needle. What device to choose, we have some time to talk about. This study, which ran from 2014 to 2018, reflects a single center experience, assessing their outcomes as the implemented FNB needles. Here, the red line on these graphs is the time when they had these needles in their practice. And about 30% of their punctures were done with these needles. They compared the number of approaches, number of passes needed to obtain an adequate amount of material for morphological examination. And expectedly, after the introduction of FNB needles, this number went lower. The second parameter evaluated was the number of adequate samples, sample adequacy with FNB needle, and this number adequacy grew throughout the use of FNB needle. To be fair, and after to be fair, even with FNA needles, adequacy of samples was growing because not only the needle design is important for obtaining biopsy, but also experience of the endoscopper. The name of that study was FNA in memoriam, FNB birth, giving us a hint that FNA is no longer needed. But if we search PubMed, which I did a couple of days ago, we'll see that each year number of publications on Usf FNA is increasing, and actually outruns the number of publications on FNB. Maybe the price is the main reason for this unchanging trend, because at least in my country, FNB needles about twice as pricey as FNA. For now, all guidelines agree on that we have quite a persuasive bunch of evidence that there is no significant difference between USFNA and FNB needles with regard to diagnostic accuracy, sample adequacy for pathological examination, and in the rate of histological core tissue procurement. However, FNB is associated with a lower number of passes for obtaining a diagnostic sample. As an example of such a study, you can see such a study of more than 3,000 patients. No difference in efficacy of FNA and FNB. But it is too early for final conclusion. on what needle to use because we need more and more tissue. And sometimes it is not enough just to answer yes or no, whether we deal with carcinoma or not. For example, nowadays, precision medicine comes in for a change our traditional approach, and more we can propose individualized treatment for our patients. For example, on this slide, we see the most typical alterations in pancreatic duct adenocarcinoma. Concurrent TP53 and SMAD4 mutations, for example, are associated with aggressive behavior and high rates of metastasis. As usual with pancreatic duct adenocarcinoma, everything is complicated, and the most commonly identified mutations with such an approach are really actionable, and most actionable mutations occur quite infrequently. About 10% of registered drug interventional trials use a biomarker stratification strategy. 10% is not too much, but this is definitely a viable direction to look forward. When we have sufficient material, comprehensive whole exome, for example, sequencing and next generation sequencing of the pancreatic tumor is possible, which facilitate preoperative genomic profile and chemotherapy fine-tuning, well, if you have the opportunity. Another direction for development is creation of organoids, simplified in vitro models of tumors with better resemblance of native tissue. They more accurately retain patient-specific tumor characteristics and can be used to test for drug sensitivity more successfully when compared with traditional tissue culture models. For now, there are not many studies on this topic. And in all of these cases, Franzen tip or fork tip needles were used like this, for example. Also suggest that it might be more prudent to use such kind of needles because at least it decreases the number of passes needed. For example, this study, which is mentioned in here, included only 20 patients, and in 13 cases out of it, tissue were obtained after only one needle pass with this type of needles. But there was no difference for size, whether it was 19 or a 22 gauge needle. Maybe these type of needles are more suitable for deriving tissue for organoids, but nowadays the data are really scarce. As a result, we see in recent European guidelines this statement. If you need just a diagnosis, ESG recommends FNA and FNB needles equally. But probably if your aim is core biopsy, then probably you have to use FNB needles, but the quality of recommendations is low. In terms of success of this procedure, EUS tissue acquisition, it is more dependent on the experience sometimes of endosonographer, of the pathologist, as well as handling of the material, rather than the needle design. These factors, however, are difficult to evaluate. Quality indicators document for EUS published in the by the American Society of Gastrointestinal Endoscopy identify the following quality indicators. Performance target for diagnostic rate of adequate sample in all solid lesions has to be at least 85%. Performance target for diagnostic rate for malignancy 70% and sensitivity for malignancy 85%. Usually when you search for papers on that topic, you find something like this. For example, retrospectively, we identified more than 463 procedures. Diagnostic specimens were adequate in 94%, and only 6% of biopsies provided insufficient samples. Sensitivity is great, 100%, specificity 93%. And yes, the use of biopsy needle did not improve sample adequacy, FNB versus FNA. Great, but usually such studies are done by expert centers, and there are high level of suspicion that in real life scenarios there are differences. And as an evidence, I'd like to mention this study from Netherlands, which gives us an interesting view of the variability of EUS tissue acquisition. 17 centers, more than 1,600 pancreatic surgeries were done. 779 of these patients underwent EUS tissue acquisition prior to surgical intervention. And the goal of this study was to define, is there a practice variation? We see that the rate of adequate samples reached suggested benchmark of 85%, but sensitivity for malignancy was much, much lower than 85. As well, we see significant variability among centers. Sometimes this indicator was as low as 20%. And even if we take into consideration more loose definition, what is malignant histology, the key performance indicator is not reached. Worth mentioning that all these are designated pancreatic surgery centers and not just general practice. There are a couple of more pitfalls I'd like to mention. For example, small masses are tricky for verification. And if we look at the group of patients with masses smaller than 2 centimeters, as presented by this group of Chinese authors, we see that they report failure rate up to 24% with Fnb needles and up to 29% with FNA needles. Another group, patients with neuroendocrine tumors, where we need not just diagnosis, but grading. This is quite large cohort of surgical pancreatic neuroendocrine tumors with preoperative EUS grading. And about 25% of patients are misclassified. Clinical impact of misclassification in this group of patients should be carefully considered, especially in small tumors undergoing observation, because tumor less than 2 centimeters and overgrading may cause inappropriate surgical overtreatment. There are no strict definition, which is a cell block. In our department, in every department, you can have local rules. And it is not even clear what to consider a core biopsy. Authors of this paper suggest a cell block is something not less than 2 millimeters. But their articles were everything more than 550 micrometers with preserved tissue architecture is considered to be a cell block. In our department, for example, we always striving to get a core biopsy. If that's not working, we do smears, and once in a while it gives us important information. But sometimes our pathologists are getting really, really small pieces like here, and they still dare to call it a core. But as you can see, this is 261 micrometers, but still it is a core. So as we see, there is significant practice variability, and we can definitely do better. We're not sure what should be done to make us all better. Definitely, the results of our work is dependent not only on the endoscopists, but on all the team, including cytotechnicians, for example, including all the nurses. We definitely have to improve not only individually, but as a medical society, and such meetings are of a great help for our education. So thank you all for the attention.
Thank you. Do you have local or general complication?
Thank you for the question. That's always very exciting moment when you do FNA or FNB, but in my experience, we didn't encounter any clinically significant complications. Sometimes we see that endoscopically through our EUS picture that there is some minor bleeding, but usually it is self-limiting.
Thank you.
Thank you. And are there any cases of acute pancreatitis during needle biopsy?
There is such a possibility, but usually we deal with patients with local masses of the pancreas. And in cases of pancreatic cancer, it is almost always coincides with pancreatitis, upstream pancreatitis. So, and in that cases where the pancreas is not intact, when it is already damaged, the likelihood of pancreatitis is really, really, really low. So that's not what we would be afraid of.
Okay, thank you. And what diameter of the needle do you prefer during needle biopsy?
Well, my personal choice is 22 gauge needle because it is some kind of a trade-off between the needle size, which you would like to be more on one hand to get more tissue. On the other side, sometimes it is technically difficult to advance the needle through the scope when it is in the D2 of duodenum. So 22 gauge needle is my personal choice, but I have to admit that you are not always capable of using the best needle you would like to because of the pricing situation. So I would like to use maybe something more sophisticated, but the price is usually sometimes can be 10 times different. So that's not always possible.
Thank you. And we have some more questions. How does the presence of chronic pancreatitis affect the diagnostic efficiency of fine needle biopsy in the cancer of the pancreas according to your data? And what is the negative predictive value of this method?
Well, that's a great question. And usually in the presence of chronic pancreatitis, we're much less able to obtain adequate material. And for morphologists, unfortunately, we don't have enough time to discuss that. But with our morphology team, we have a lot of discussion on this topic. It is very, very difficult to get the correct diagnosis either by biopsy and morphologically wise. So the sensitivity and specificity drops significantly. I'm not ready to give you exact number of the negative predictive value, but it really, really varies a lot between centers. It depends on a lot of factors, and well, that's not great at all.
Thank you very much.
Approximate percentage, I can say that sensitivity is dropping about 74%. Sensitivity drops. Negative predictive value, give me some time. I can search for the result. I will answer in the chat.
Okay. We are ready. We are ready to proceed our next presentation.
Yes, now we have the third report, endoscopic papillectomy compared to surgery for non-invasive lesions and early ampullary cancer. Markus Hollenbach, please, you have 15 minutes.
Dear colleagues, my name is Markus Hollenbach from the University of Leipzig Medical Center in Germany. And today I will present you the results of our multinational project analyzing endoscopic and surgical therapy for ampullary lesions. And the first slide is on my conflict of interest. I think this is not relevant for this topic. And I think you all are familiar with ampullary lesions. You all know that these are a rare condition, and it has a prevalence of 0.1% and accounts for less than 10% of all periampullary neoplasms. However, in particular in ampullary adenoma, there is a potential for a malignant transformation to an ampullary carcinoma, and therefore a complete resection of non-invasive ampullary lesions is indicated. And this can be performed either by an endoscopic pabblectomy and transduodenal surgical ampulectomy or a pancreatic duodenectomy. However, there are only case series published so far, and comparative data between the procedures are lacking. Here is example for a standard endoscopic pebblectomy. You can see the ampullary adenoma here, and there a snare is surrounded about the lesion. And then we will cut the lesion without submucosal injection because this is a risk factor for incomplete resection. And then you can see here the resected specimen. And after the resection, we will implant a pancreatic duct stent to prevent the post-ESCP pancreatitis, because this procedure is a high-risk procedure for such a complication. I think you all are also familiar with the surgical interventions. On the right side, you can see the pancreatic duodenectomy, either as a classical Whipple procedure or a pylorus preserving procedure. And the other surgical method is the transduodenal surgical ampulectomy. There you perform a vertical or horizontal incision of the duodenum, then you resect the region of the papilla with the lesion, and then you do a reinsertion of the pancreatic and the bile duct. In our so-called ESAP study, we included 58 centers and performed a multinational, multi-center study. We were able to collect data from more than 1,400 endoscopic pabblectomies, more than 250 TSAs, and more than 1,100 PDDs. At the moment, there are several ongoing projects, and today I will present you the data of a propensity score-based matching analysis, and we compared the efficacy and the complications of the pabblectomy compared to the TSA and the pabblectomy compared to the pancreatic duodenectomy. And we matched for age, gender, size, the histologic subtype of the lesion, and the ESA score to provide comparative data between the groups. And of course, we only included non-invasive lesions and early ampullary cancers limited to T1 stage, because lesions of T2 or higher are no candidates for an EP. You can see here the distribution of the centers. The main centers were in Germany and France, but we also included centers from Asia and from the United States. These are our results. Out of the more than 2,000 included patients, we had to exclude a lot of procedures because either the matching criteria were missing or the main outcomes were missing. And at the end, we were able to perform a perfect propensity score matching out of 77 patient pairs of EP and TSA patient and 151 pairs of EP and PDD patients. You can see the graphical visualization of the matching, and you can see that the matched cohorts of the EP and the TSA and the EP and the PDD groups are well comparable. These are our results. If we focus on the EP and the TSA group, then we can here clearly found that the baseline criteria regarding age, the gender, the BMI, the ESA score, the comorbidities, and the clinical presentation of the patients were quite comparable. If we have a look at the outcomes, then you can see here that the lesion was not significantly different in size and in the histologic subtype of the lesion. The main types were low-grade and high-grade dysplasia, but we also had some early advanced early invasive cancers, and we had some hyperplastic lesions. This may be a result of a biopsy error between the initial biopsy and the final resected specimen. And we also had some very rare lesions like neuroendocrine lesions and the paraganglioma. And you can see here that the initial rate of complete resection, the R0 rate, is quite comparable between the EP and the TSA group, is about 87 and 90%, which is quite optimal. And even in the patients that received R1 resection, then in a repeated intervention, we were able to increase the rate of complete resection to 100%. Also, if you have a look at the recurrences in the R0 treated patients, they were very low and they were comparable between these groups. Also, if we focus on the complications, then you can see here that we compared the severe complications classified as ASGE as severe or enclavidindo more than 4 points, then you can see here that the complications were comparable between the group and not significantly different. But however, the duration of the procedure and the length of hospital stay was significantly longer in the TSA group. We move on to the EP and PDD calculations. Then you can see here that also the baseline criteria, like age, gender, and so on, are comparable between the group. And if you see the results, then also the size and the histologic subtype were quite comparable and equally distributed between the groups. And however, the rate of complete resection, of course, was very high, was 100% in the PDD group, but only 84.8% in the EP group, what was statistically significant different. However, if you have a look at the repeated interventions, then we could show that if you perform another EP or another 2 or 3 EPs, or in combination with an ablation therapy of an argon plasma coagulation or radio frequency ablation, then we were able to increase the rate of complete resection to 91.3% in the EP group, and this was not statistically significant different between the groups. Also, if you have a look at the recurrences between the groups, there were no significant difference, but if you have a look at the complications, then there was a dramatically higher rate of severe complications in the surgical group of 17% compared to 3%, and we had 3 deaths in the PDD group. That means that although this resection was very efficient, we have a high rate of severe complications in this group. And of course, the length of hospital stay and the duration of the procedure was quite longer in the PDD group. So I may conclude our results. These are the results of the first propensity score matching of a largest cohort of ampullary lesions that were treated endoscopically or surgically. And we could clearly show that the pabblectomy is comparable to surgical ampulectomy, but it showed an initially lower rate of complete resection compared to the pancreatic duodenectomy. However, we were able to show the efficacy of an endoscopic retreatment, and we highlighted the dramatically higher rate of complications in the PDD group. Therefore, to our point of view, the endoscopic pabblectomy should be the first choice of treatment for ampullary lesions in selected patients. That means patients with an adenoma or early ampullary cancer. Thank you for your attention.
One question, please. Do you have duodenal perforation duodenum by endoscopic papilectomy, please?
Yeah, thank you for your question. We do not observe this complication in the EP group. And if you have a look at the literature, this is a very rare complication, a duodenal perforation.
Okay, thank you. And in your opinion, in which cases is there a necessity for endopancreatic stenting during ampulectomy?
For when you perform an endoscopic papilectomy, do you think? I think you should always try to insert a pancreatic duct stent after the resection, because the endoscopic papilectomy is a high-risk procedure for post-interventional acute pancreatitis, and you should always try to insert a stent, no matter if you do a rectal endomethacin or something else.
Thank you. And do you use saline injection during resection of ampullary tumor?
Yeah, there is a clear recommendation from the ESG that you should no longer use submucosal injection during the EP. However, our database included cases that were dated back more than 10 years. So we also had some cases that were treated by submucosal injection, but actually it's no longer recommended. Yeah.
Okay, thank you. And in your opinion, in cases of ampullary cancer, do you prefer performing endoscopic treatment or pancreatoduodenal resections?
It strongly depends on an adequate staging. That means if you perform a correct staging and you excluded lymph node metastasis or distant metastasis, of course, and you are sure that it's an early cancer, T1A or T1B, then I think you should go first for an EP if you are feasible to do it, if you have the experience and all the setting to perform such a procedure. Otherwise, go for a surgical treatment. And of course, if you have advanced stages of cancer and T2 cancer or higher, then of course you should go for surgery if possible.
Okay, thank you. Thank you very much.
Thank you very much. Our section is finished. Thank you. Everyone would like. Goodbye.
Thank you. Bye.